and see if they apply. So that's one of the nice things. But to find out how they started their program, how they go through their practice, find out about some of the pitfalls, some of the problems they had, some of the barriers they had to moving residencies forward. One thing in the United States is we do pay our residents a stipend, but through our graduate medical education, some of that money has actually come back to the hospital. So that is one thing that it takes a couple years to actually get those monies coming back, but we find that we actually can support a portion of the resident's salary through our payment system. That only works for PGY1 at this time. We don't have that same benefit for our PGY2 residencies, but at least that helps when you're trying to justify adding a position or 2 or 3 positions within a hospital setting. Okay. So, I'm running close on time, so I'm going to run through, but basically the steps for the residency accreditation are out on our website. We have a goal, and I've stated this several times as we've moved forward. But part of that goal is not just to have people residency trained, it's the purpose for residency training. And there is a benefit for our patients, for the organization, and for the profession. We're looking at advancing our patient care skills. So we're looking at raising the level of practice for our pharmacists in the areas of medication use, in the areas of evidence-based medication, in the areas of informatics. For the patient, they have a highly skilled practitioner that's taking care of them. They have a highly skilled pharmacist that's an integrated member of the healthcare team. And they see that the pharmacist is responsible for their medication therapy. So it's access to the healthcare professional that knows the most about the drugs. I've mentioned several times the leadership skills. That is supported, enhanced, and reinforced within our residency training programs. For the organization, I did say that residents are a lot of work, but they bring value. They will challenge your staff. They will challenge you as a residency program director. And they will also give back. Because not only is this a training time for them, but some of the activities that they do, what they bring as far as their outputs, some of the projects that they're working on, some of the areas that they'll be working on for research is beneficial. In addition, you have a 1-year interview. So as you look at the residents as they go through, you see if they're going to fit into your organization and where they will fit into your organization as you're looking at continuing to advance practices. And then for the profession, I'm not going to cover all these points, but I think part of this whole conference is looking at how are we advancing practice. So how do we look at where we're going within pharmacy, and again, what is the role of the residencies? So I have a slide up here. The development of strong residencies in hospital pharmacies is fundamental to the profession and to the development of strong services in our hospitals. Now, we've quoted many recent leaders this morning, whether that be Bill Zellmer or possibly Henry Manasseh, but this quote itself is from 1964. It came out of a publication called Mirror to Hospital Pharmacy. So we actually had a statement quite a while back. And I'd say we're coming close to achieving it, but it does take a long time. So with that, I do have some slides of references, and I can share these offline if someone would like other copies of them as far as where we need to go. But thank you for your time, and hopefully you are thinking, if you don't already have residency programs, that you're thinking about implementing them at your sites.
Thank you, Christine. And there will be opportunities for questions in the group discussion session after our final presentation, which is going to come from Professor Martin Henman from Ireland. Professor Henman is a world-renowned and world-respected educator in the profession. He is currently the Associate Professor in the Practice of Pharmacy and Coordinator of the Center for the Practice of Pharmacy, School of Pharmacy and Pharmaceutical Sciences, Trinity College, Dublin. He's a member of many national and international committees and institutes, including the Irish Institute of Pharmacy. He's a consultant for the European Directorate for the Quality and Safety of Medicines and Pharmaceutical Care. He's also a member of the reference network to the European Health Alliance Consortium, conducting a review and mapping of continuous professional development and lifelong learning for health professionals. Professor Henman is, as you will see from his introductory comments, both involved with the professional education or undergraduate education of pharmacists, but also the continuing professional development of pharmacists. And his presentation this morning is going to talk about science, practice, and ethics, foundations for a healthcare professional. And I know that he's going to give us some interesting thoughts and ideas to stimulate your thinking on the subject this morning. So please join me in welcoming Martin Henman. Thank you, Martin.
Thank you, Michael. It's a great honor to be invited once again, so I thank the organizing committee and the opportunity to return to Oman and to speak at this excellent conference. Science, practice, and ethics as foundations. I think it's true, but I'm also going to challenge you a little bit in terms of that, to think of them rather differently from that, and in particular, to think of them not merely as something which holds up a structure like this building, but instead as something that will empower and help us to evolve practice. The basic arrangement for the development of healthcare professionals set out on the slide here has usually been that of an undergraduate qualification of some sort, which once attained then enables them to go on to seek their licensure, their registration, qualification for their professional practice. And associated with that is usually in a period essentially in the past of apprenticeship in a suitable healthcare center in order to gain that experience. After that then we move from being novices on to being more experienced practitioners, and with the help of continuing professional development, which is the term I'm going to use rather than continuing education, to carry on and further develop our capacity to provide care to patients. But however, in the last 10 or 20 years, things have changed quite a lot in that we no longer accept that people, once qualified, are capable of staying qualified for the rest of their lives. So as in most countries, it's necessary to recertify, to become relicensed in order to continue to practice. And this is part of the reason why we need to look at areas like quality assurance, as we heard from Michael in the first speech here today, to make sure that the quality of education and the quality of training, as you've just heard from Professor Jalowski, will be adequate to the task. Moreover, we also have moved now to a stage in which we are no longer not only not suitably qualified to stay as we were, but frequently we will be challenged to do something different, to provide a new service, to extend the scope of our practice, to change the scope of our practice, and for that we also need to go on and get further training. So although I'm going to talk a lot about undergraduate training, that's not only what I'm interested in. Science, ethics, and practice essentially were separated by the healthcare professions themselves. In particular, medicine felt the need to establish its educational quality, and so therefore it took its programs, put them into universities almost from the very beginning, and established them there, and to a great extent separated the teaching of science from the practice, the learning about practice. But in both medicine and to some extent also in nursing, which undertook that transformation rather later on, the approach to practice was possible for them because they retained patients and they retained a base within the hospital into where they could therefore easily go for their training and their practice. Pharmacy has always found that rather more difficult for obvious reasons. Ethics was also tended to be left until that later professional stage of training as for teaching. because it's always been seen as something which is rather separate. And as already been said this morning, I don't think that's the case, and I hope you don't either. So professions then, with their specialist knowledge and skills, their integration of practice experience in order to achieve their final qualification, are setting out, of course, to serve their clients, to serve their patients. If we look at the educational context for pharmacy then, what we see is, and broadly speaking, I've divided the world into three parts here. It's not entirely accurate, but nevertheless it gives a good flavor to how things have come. Pharmacists who are scientists, very much a Central European tradition. You tend to see them, therefore, with a very strong science base in their undergraduate education, with maybe a few percent of the entire course devoted to practice and to things related to practice. They also have tended in the past to have continuing education rather than continuing professional development. For them, becoming a practitioner meant leaving with the qualification and going off to take up the apprenticeship as they would see it. In North America, the pharmacist is really a clinician. And that's the aim of the courses and the work of Professor Jalowski and her organization and other American organizations, is essentially to produce clinicians. In the UK, in Ireland, in Australia, not surprisingly, countries with similar backgrounds, there's tended to be the approach to say, well, we should in actual fact create a generalist through the undergraduate education and then help them move on from there, and that we will try to integrate some of these elements, particularly the science and the practice, in the undergraduate education. And at the moment, what is going on in all of those countries is a drive to integrate all elements into a single qualification, starting as the first qualification after leaving school, in other words, an undergraduate degree, which will bring them all the way through. And then, rather less so, further continuing professional development and specialization. So, most of the other speakers this morning have been fairly fundamental. They have focused on some fairly practical issues. Much of what I have to say is in actual fact really about how we think, so it's rather more abstract. Science, practice, and ethics are different types of knowledge. They are not the same. We learn them slightly differently. We need to deal with them rather differently, and we need to be aware of the differences in order to utilize them as best we can. This hasn't ever really been much of a concern within pharmacy, not even within pharmacy education. But if you look at the literature in medicine, in nursing, in dentistry, you see that they are quite concerned about this. Nursing in particular, which after all has always had the very strong caring role, needed to work out how to integrate the science it was learning to underpin its nursing and help with that, and also then learn how to, as it were, demonstrate to other people the value of what nurses learned in practice. So they have had a lot of discussions around this. So the subject is usually known as epistemology. Pharmacy, on the other hand, has tended to concentrate on methods and content and so on. And as we've seen, the different types of approach to training pharmacists. However, it adopted a very scientific approach in the first instance and separated the teaching of science from the teaching of practice. This separation, of course, comes about partly because universities are constructed with strong disciplines of chemistry and pharmacology and so on, and allied to those disciplines, therefore, there is an organizational and, of course, a certain power element within the running of the university. These days, it is allied to research, to the need to publish, and so on. And that has tended to act as a barrier to integration within courses, and in particular, a course like pharmacy, which was trying to change from being a science-based course to being a science-based course which is providing a healthcare practitioner, required a tremendous transformation. And so that's always been a difficulty. The division damages the student. One of my contentions is that we cannot wait for integration later on. We need to start out with an integrated educational system in order to enable people to be able to work with the different types of knowledge and then better to choose their own path and better to contribute. In particular, this is very important for ethics. So, the first two definitions, which are my definitions shown on the slide here, essentially read the same until almost near the end, because the commonalities between science and practice, between the way in which the knowledge is found, how it is assessed, and how it is used, are very similar. It is the practical application which is different. In the case of the practitioner, the knowledge is required for patients. The risk of damaging the patient is very substantial. The time frame is very often very short. So the care must be provided. It must be provided now, not at the time of our convenience. So all of those things are difficult for us to work with. You perhaps have begun to get the idea that in actual fact I have certain ideas about how knowledge comes about, and that's true. I would be called a constructivist if we were at a different type of conference. In other words, I think that we see the world and we put a structure on it for ourselves. We construct our knowledge and our learning, and that is how we end up seeing the world. We learn from others in that process, and we think about what they have taught us and how, whether that will change our view. And that's important. We can measure that. We can show how that works. We do it as individuals. We do it as groups. We see the trends in pharmacy education and in pharmacy at this conference, and they represent how we see pharmacy and the knowledge of pharmacy at the moment. What you will notice is that the commonalities in science and practice are around the rigor with which the two are done, because information must be fully disclosed and then must be rigorously examined. In practice, however, because of the pressure of time, because of the difficulties associated with incomplete information, it means, therefore, that things must be sometimes done before we have all the information we need, before we are really ready. And quite often, of course, we come to a conclusion about what is wrong for a patient and how we might help them, and then we give them a drug to see if that is right. Usually we are right, and that's good. So we learn really in three ways. We learn from external sources, usually in our case largely evidence-based sources that we use to build up our knowledge. We also learn from accumulated experience, experiential learning. And the structuring of that experiential learning, as you've heard, is very important. In particular, we also then have another type of knowledge which is ours, which is probably unique to us as individuals. And that's usually referred to as tacit knowledge by a man called Michael Poliani, and in nursing and dentistry, it's usually referred to as craft knowledge, things that you know about pharmacy because you know them. You're not entirely sure how you know them, but you do. And of course, what we want to be able to do is to move ourselves around that cycle that you can see in the bottom right-hand side of the slide. We want to be able to integrate that knowledge. We want to be able to reflect upon it in order that we can restructure our understanding of the world. Now, these people up here you possibly have seen a few times, and if you look at those programs carefully and listen to what goes on in those programs, you will find that in actual fact that's exactly what they're doing. And that most of them have some level of tacit knowledge, some personal, some craft knowledge that they have, that they apply to the problems that come up in those fictional depictions. And they are reasonably accurate fictional depictions. The gentleman on the left, House there, as you know, is probably unbelievably dysfunctional. I don't see how he ever graduated from medical school, but there you are. He nevertheless is the one that they come to because his level of tacit knowledge is so great that in actual fact he can continually work through the problems. Now that also leads on to something else, because it also shows that within the group, particularly if you look at the Scrubs group on the right-hand side, there are different people there who like different types of knowledge and are better and more capable of working with that knowledge in different ways. And that's quite important for us too. In pharmacy, knowledge is particularly uncertain. After all, most of the time, the drugs that we use produce largely the therapeutic effects that we expect, and also the adverse effects that we expect. But they don't do it all of the time in every single patient. So that means there are a minority of patients in whom something unexpected is happening. Moreover, when we're dealing with the circumstances, we don't usually have all the knowledge that we want at the time, and we do not necessarily have it at the time. My young students, for example, tend to want to give somebody an antibiotic on the basis of having got the results back from the laboratory, which tells us exactly which organism it is and whether or not it is sensitive to the antibiotic that they want to use. They find living with the uncertainty very difficult. We need to learn to live with that. We need to adapt to this problem of the fact that individuals vary and that our circumstances put us in a situation in which we must move ahead. Moral reasoning is particularly an area in which we must do this, because we must consider how the other person's values, how they will affect the problem that we're thinking of. Ethics, in actual fact, was at the center of pharmaceutical care, the theme of this conference. And you can see here, this is very much a Doug Hepler quotation, that pharmacy must restore a clear emphasis on the patient's welfare, a patient advocacy role with a clear ethical mandate to protect the patient from the harmful effects of drug misadventuring, of things going wrong. As Mike Rouse said, ethics used to be taught separately. We hope it isn't taught separately anymore. It used to be taught as ethics and law, as though it were a standalone piece of information, a standalone piece of knowledge. And unfortunately for pharmacists who have to worry about standard operating procedures and so on, that tends to reinforce the idea that that's how we should look at it. In actual fact, of course, much of our moral reasoning is largely intuitive. It's largely tacit knowledge. We think we know what is right from wrong, and we have seen other people do things before. Also, the society and the environment in which we work plays an important part of it. Much of the principles of bioethics that are being taught and promulgated at the moment are very much a Western European view of ethics. They don't necessarily entirely accord with all other cultures. We also know, however, that in actual fact, when we work in an ethical way, that if we do something wrong, or if we avoid doing something, that in actual fact this produces feelings of unhappiness in us, of discontent. And that leads us, therefore, to avoid doing things even more in the future, to become more passive, to become what I have sometimes called clinically inert. There has always been a feeling that you couldn't teach ethics, which is why it was pushed into the practice side, because they'll learn it when they get there. When they are faced with these problems, they will become real to them, and then is the time for them to learn. But in actual fact, we need to bring it into the curriculum to do that. And we know from looking at neuroscience work, which has been done in the last 5 years, that in actual fact, content and context, that norms and culture, and also that the emotional effects of making moral decisions are important. And we can use this information to help us with the teaching of ethics through the normal curriculum. So, if we set out to resolve some of these problems, the separation of these different elements, the understanding about how we think, about how we know what we know, and also the look at ethics, we should be able to move on then and produce better curricula for our pharmacists and continue them on beyond, in actual fact, graduation. We need, quite crucially, to take a developmental approach, and you can see that coming through in the things that Professor Jalowski's talked about as well. There is a clear progression in the American system onto the process of residency training. There is a clear progression for all of us from being students to then being novices and then gradually progressing on to a more advanced state. And we need to accept that that is the case. And the quotation I have here, which is 2005, shows it. In actual fact, I could give you a quotation from 1898 from Whitehead, Alfred North Whitehead, who was a famous educationalist in the US, who said this something very similar. So we want, in particular, to try to set up a circumstance in which the content is not independent of the context.